Take your call. Thank you.
A very good evening to everyone. It's a pleasure and honor to welcome you all to this Pancreatic biliary Colloquium. This gathering of brilliant minds, skilled surgeons, and dedicated professionals stands as a testament to the continuous pursuit of excellence in the field of surgery. Today, we are not just here to discuss the procedures or the intricacies of the operating room, but also to share knowledge and collaborate towards advancing surgical science. It's a gathering like these that serves as a backbone for the progress where ideas are exchanged, challenges are addressed, and solutions are forged. We have a fascinating program ahead of us filled with insightful presentations and discussions. So let's make the most of this colloquium. Now, I request Professor Dr. Mushtaq Chalku, Organizing Secretary, to welcome you all with his warm words.
फानूस बन के जिसकी हिफाजत हवा करे वो शम्मा क्या बुझे जिसे रोशन खुदा करे. Assalamu alaikum. Thank you very much for joining us this evening. I am honored and humbled to see my teachers, the stalwarts here of HPB, our worthy ex-director, Professor Shaukat Zargan, Professor Umar Javed, Professor Salru, Professor G.K. Peer, and our guest is looking at me, sir. How could this evening we could complete with our presence? Thank you very much for joining us today to make this evening, which has an idea and a theme, to celebrate what the Department of Surgery has been doing for the last 25 years in the minimal access surgery. I must not fail. I would also thank Professor Ejaz from SKIMS for joining us. Many more people probably would join us. It has become very difficult to get into the conferences because a lot of conferences overlap. Dr. Professor Mubashir, thank you for joining us off ARC. The problem is that a lot of conferences are happening, and I was told by Professor Ejaz, HOD SKIMS, that there's a conference at Kobu. So I requested him kindly divide the faculty so that our program also gets equally enlightened. And the idea to celebrate this evening is not less than, we call it a colloquium, we call it a Carpe Diem. Thank you, Dr. Arshad, for choosing these choosy words, and they are specifically describing the theme of today's evening. And I welcome Professor M.S. Kuru. We're honored and humbled to see him. So thank you, sir, for coming. Your presence has added further grace to the occasion. So I was talking about the colloquium, and Carpe Diem is not just fancy words. Let me honestly tell you, it conveys the theme of today's evening. And I must tell you that what has happened for the last 25 years, when you look at that skyscraper, look at that peak, you forget that this stands on that simple stone that has gone down. And because of that simple stones, we are celebrating the peak today. This is truly a Carpe Diem, a festival of Eid for the Department of Surgery. And I'm thankful to my HOD, Professor Iqbal, and collective my heads of the units who opined that why not to celebrate it as an Eid? Because you can understand that the Eid is the peak, and probably the Department of Surgery is one among in the North India to celebrate this peak. And this is not, I must not fail to congratulate all those pioneers, those stalwarts who have gone through troughs and crests, through thicks and thins, through tears and smiles. It's an untold story of tears that gets into this peak to celebrate. We call it Carpe Diem. So I will sit down, believe me. I'll sit down to stand up. And I request you, please put your hands together for all those pioneers. The one is yet to come from our own institution, Professor Munir Khan, who laid this foundation. And sirs, let me all tell you, thank you very much. We are at the peak. And I'm sure the legacy will continue. We are not bothered about our future because we know our today. And I'm sure our tomorrows will take care of themselves. And that's the idea of the department, to leave these people who are at the backbench. They will be here after some time, and we will be here with Professor Kuru sir. And that's how the legacy will continue. And that's the idea and the purpose of living. Let me tell you that this is not me talking like this. This is physics. I have a reference. And those of you who know physics will know that when you stand on that peak, it may be difficult way. Professor Umar is here. The way to pancreas is a dusty way, is a misty way, and it takes an age to reach there. That's why God put it high up. At the back, the surgeon will fiddle it at the end of his career. But this way, you will have to pass through a crawling time of all these roughs, crusts, tears, smiles, hard work. This is a total gamut of this. You will have to go to reach that there. But it may be equally difficult to stand on that peak, because physics says as you grow up, the winds will flow. They will debacle you, destabilize you. And yet the art is not the political gimmickry. The true art is, it's pure art of staying there with your hard work, persistence, continuous work, patience, and beyond that, passion. Believe me, there's nothing short of that. Don't get into the world of political gimmickry. It is simple hard work that puts you up. And staying there should not be stopped. I am sure the people in the next generation will go and explore the newer peaks and enlighten for the benefit of patients. That's our ultimate aim, the research and the teaching. I once again thank you very much. This is what the department is collectively doing, and my aim along with my HOD was that we call all of you and get enlightened with these masters in the subject who need to be given a standing ovation. I am honored and happy that you are. So with that, I once again think that I'm sure I wish you best of the presentations of all the speakers. We have Dr. Sanjay with us, and I would also thank all of you for joining us this evening. Let's hope we make this evening pleasant and academic evening. Thank you very much.
Thank you, sir. I would now like to invite Professor Dr. Iqbal Salim Mir, President JAKASI, to address you with his charismatic words.
Good evening, everybody. Assalamu alaikum, Sat Sri Akal, Adab. So it's for everybody because we are in a republic. Let's hope we continue with that. I have got stalwarts before me, and if I start naming them, then I think I'll take more time than Professor Chalku. And since must thank my predecessors who made sure that we have enough equipment in our hospital that we can deal with pathologies which were unwelcome to our department. But now it has become a routine with us, whatever surgeries are coming. A special mention about one person, Professor Umar Javed. He is the person who started the fire, in our belly. And it has reached an extent that now we are thinking beyond what we normally would think. I am very happy to see the Professor Kuru here, Professor Shaukat Zargar, and I must thank Mubashir also. He has taken time out of his own this department and come here. Can we have clap for him? And I already said that all my senior colleagues, Professor Salu is there, then Pir Saab is there, Javed is there, then Sir Nisar Saab. I should not forget him and all my colleagues. I must thank you. You have made JAKASI. This is a program of JAKASI. Let me make it very clear. It's not only the Department of Surgery. This is a program of JAKASI, and we want to make sure that our youngsters learn and they're exposed to something beyond the routine that they see in the hospital. So I wish everybody luck, and I'm sure that I have just 6 or 7 months left. I'll try my best as President JAKASI to see that we have more of such conferences, such interactions, so that all my youngsters, they are in a place where they'll replace us without any ado. Thank you very much, and let's hope you enjoy the evening.
Thank you so much, sir. We will now be starting the first session. For that, I request Professor Dr. Shaukat Zargar, Professor Dr. Ejaz Rathar, and Dr. Nisar Ahmed Wani to kindly chair the session. Thank you.
Car number 8633. We need the key. 8633. Hyundai Avenue.
Good evening. Welcome you all for this first session. And the first speaker will be Dr. Nisar Ahmed Wani, and he will be talking about the prospective management of ruptured hydatid cyst. Dr. Nisar Ahmed Wani.
Good evening, everybody. This is quite nostalgic moment. This is a nostalgic moment, sir. I am seeing my teachers in front. Professor Kuru sir will not be knowing me. I have been in junior resident in gastroenterology in 1994. So I have worked for 1 year in your unit. I feel really, I remember the time when shivers will go down the spine when I had to present in front of him. And today I am as a teacher, as a student, presenting this small presentation which at the 11th hour, Dr. Iqbal, my friend, told me to present, though it was not in the agenda. So I could comply because we have to carry on this. No, no. So there was a technical hiccup. I bring greetings from my place, Government Medical College, Anantnag. I am heading the Department of Surgery there. As we all know that we have teachers and many stalwarts here who have done a lot of work on Hydatid. I don't need not to go into the details. Everybody knows the basics. That's echinococcus which causes this. Liver is the most frequently involved organ and followed by lungs. It can potentially impact any organ in the body. So important thing is that intraperitoneal rupture, which is very rare. We have seen many patients in the casualty which present as acute abdomen. It's why the idea was to present this patient. Rupture occurs because there is increased intracystic pressure and peripheral location of the cyst in the liver. It can be spontaneous or it can be due to trauma also. So presentations in such patients in Hydatid is that you can have abdominal pain, urticaria, anaphylaxis. Sudden death can occur if there is a rupture. And clinical evaluation and radical imaging confirms the diagnosis. And appropriate timely intervention and medical management will definitely help in these patients. I am presenting a case of 9-year-old girl which came to us in the casualty, which presented as pain abdomen, which was around the umbilicus and the right upper quadrant. Once we evaluated this patient had no fever and there were features. Vitals were by large normal, and inspection patient had a sluggish movement of abdomen on the right side. There were no features of allergic reaction. Palpation, whole abdomen was tender, it was more on the right side. Percussion dull note on the right side of the upper abdomen, and auscultation showed sluggish bowel sounds. Investigations by and large were normal except there was leukocytosis. Enzymes were mildly elevated with bilirubin of 2.1. And once we did USG of this patient, it showed an intra-abdominal pelvic fluid collection and a heterogeneously hypoic area measuring 10 into 8 into 8 centimeters, involving the right lobe of liver with multiple septations within the abdominal collection. CCT of this patient showed rupture of anterior cyst wall with presence of multiple laminated membranes in the right lobe of the liver, disseminated in the Morrison's pouch and right pericardial gutter with fluid up to the pelvis. Immediate resuscitation was done in this patient and we subject this patient to. These are the CT and ultrasound images. Can you hear the video separately? Video. So once we went in, we saw this picture. There was a jelly-like covering around the cyst, and the cyst was engulfed by the omentum. It was ruptured. Omentum, this laminated membranes were hanging from the roof of the abdomen. And once we tried to probe in, there was hydrated fluid was in this cavity. It was full of hydrated fluid. So what we did first, we saw floating laminated membranes engulfed by the omentum. So we tried to aspirate first a whole hydrated fluid. We tried to localize it. We did not try to remove the adhesions at the first go because we wanted to have fluid there only, not to damage. Though this is disseminated in the whole peritoneal cavity, and pelvis is always also full of this fluid. Being a young girl of 9 years, we thought it's better to do it laparoscopically. Though patient has presently examined emergency, we don't have facilities, so we took her up in the our routine OT and tried to do it in the because it was a daytime. We used this sucker tip to separate these all flimsy laminated membranes which are adherent to the peritoneal wall. This is the area where it has ruptured, liver, right lobe of liver. So after trying to aspirate as much fluid as we could, we put scolicidal agent betadine and waited for 5 to 10 minutes to act. We had to sprinkle this betadine in the whole abdominal cavity because of the dissemination. Then we put an endo bag to collect the laminated membranes into this. We use simple bag of this drain bag. We don't have sophisticated bags available. So we put the laminated membranes into the bag to salvage all the laminated membranes which were around. These were just spouting out of the ruptured cavity. So after doing this much, we could see laminated membrane is wrapping the omentum also. So we have to peel off it from the inflamed omentum, these whole membranes. So after removing from this omentum, we could see that there were many fragments of the laminated membranes adherent to the small gut also. So this is small gut loops which are also surrounded by these laminated membranes. Then we, after trying to remove as much, we entered the cavity where there was rupture of the cavity. This is the cavity in the right lobe of the liver, which has this adventitia also quite a bit of 1/4 of the cavity is adventitia. We again put betadine inside the cavity and waited for 5 to 10 minutes, and then again we aspirated and tried to remove the remnants of the laminated membrane inside the cavity. There were many membranes also ruptured inside the cavity which we tried to salvage. Then we tried to do partial pericystectomy and try to remove as much adventitia which was away from the liver so that we could make a big opening in the cavity so that there will be no collection and we can visualize the cavity properly for any biliary leak. We are lucky to have these gadgets which help us make our life comfortable, harmonic. So after doing this, we again aspirated all betadine, and it's an edited video, and we got right from the ileocecal region up to the DJ. We freed the gut, we cleaned the gut with normal saline, and then we put a drain and came out. Post-operative patient was put on albendazole therapy. As you know, this was an elective case to give preoperative albendazole from first post-operative. Tube drain was around 300 ml on day 1 and subsequently decreased to 20 ml on 7th post-operative day. Drain was removed in follow-up OPD after 7th day. More than 3 months of follow-up, she is doing quite well. So to discuss that, we have many complications of hydrosis. Rupture is around 0.9 to 16%. Then can be infection of the cyst. Anaphylaxis can occur. Compression of adjacent structures like vascular and biliary can cause sometimes obstructive joints like picture also. So there are many ruptures. There can be internal rupture causing cystobiliary fistula, bronchobiliary fistula, intraperitoneal rupture, intrapericardial rupture, intrapleural rupture, all these have been reported. Externally, even cystocutaneous fistula has been reported in the area. What are the predisposing factors for rupture is that young age, because in young age there is quite a long time that it can increase in size, and cyst diameter more than 10 centimeters is a predisposing factor, and superficial location of the cyst is the most predisposing factor in these patients. Then, as far as management of these ruptured hydrocysts, we have American College of Gastroenterology guidelines. They recommend either you should go for open or a laparoscopic surgery. Objective of surgery should be to aspirate hydatid fluid, extraction of laminated membranes, irrigation with colicidal agent, and subsequent wash with normal saline. You have to look for any biliary communications like if there is any communication, then you go for suturing, you go amentopaxy, you do T-tube insertion, fevary decompression or effective external drainage. Sometimes in post-operative period, the biliary leak continues, we may have to go for ERCP and sphincterotomy. Then, what is the follow-up in these patients? You have to start immediately albendazole therapy 10 to 15 mg per kg body weight for 6 months to 1 year in the follow-up. Monthly for 1 year screening should be done for recurrence like ultrasonography, IgM ELISA for hydatid, IHA, CT abdomen sometimes is needed. And after 1 year, yearly follow-up is to be done. Then you terminate the follow-up after 5 years. Recurrence rate is 0 to 28.6% in ruptured hydatid cysts. To conclude, the complication of hydatosis must be included in differential diagnosis of a patient with acute abdomen in an endemic area. For our young surgeons, when our child comes with this, we have to keep this thing in mind that it can be a rupture, neither she had an anaphylactic reaction. Intraperitoneal rupture is a rare but serious and life-threatening complication. Management and treatment depend on immediate surgery along with medical management. Patients should be kept for strict follow-up as there is chance of high recurrence rate. Thank you.
Dr. Nazir has always been a daring surgeon. He is the first surgeon to do and perform an abdominal resection in a district hospital.
Sub-district, sir.
Sub-district. And has worked with me for some time and is a very good surgeon. Well known in Anantnag also at this time, also well known surgeon. And he has performed surgery very nicely. Open to discussion. If any questions or queries, kindly.
Now we go on to the second speaker of the session. It is Professor Mushtaq Chalku, who is going to talk about minimal invasive surgery in pancreas, away forward.
Can we have the lights, please? Can we have the lights? I'm sorry, in my welcome address, I must have forgotten many names who are my teachers. To take a name of Umar Javed Shah, without his guidance, probably this work would have not been complete. I salute you, sir. I will sit down and salute. I thank you for giving me chance. My department has trusted me to carry this show. And we are in this field for last around 20-25 years. And we're trying our humble way of getting this minimal access to the best of possible care in the state level. And this kind of job, probably, there are only few centers across the North India which hold this job. Professor Kuru will stand witness to that. Professor Zargar is here. They have seen a lot of life. They are the senior people in this. It's an endo-lapro wedding, you can say. And you can have to wed the two to get into this. And this kind of job has taken a lot of efforts of all those stalwarts and pioneers. Professor Munir is not here. Professor Khan Saab was supposed to come. He said, I will be there. So my salute to him also. It's because of that stone we stand at the peak today. Thank you very much. I felt like I will give you just an overview of what we are doing and handling pancreas. Because pancreas is a very fastidious organ. It takes a lot of a distance to travel. No wonder it is distantly placed, because by that time you need to be aware about, and one should not travel to this organ unless you are very aware about how to handle stomach, at least with D2, then go beyond and beyond. So that's my way. I'll just give a outlook of what we at Department of Surgery are doing. And we all, Professor Iqbal, Professor Atri, and me, Professor Shakil, everybody is doing. Our roads might be different, please. Our roads might be different, but our aim is same. We go by open way, we go by laparoscopic way. So this is the total historical view. Thanks to Gagner, who started with first laparoscopic pylorus preserving pancreatic with 94, laparoscopic distal pen 95, laparoscopic pancreatic which is 99, laparoscopic radical modular pancreasplenectomy is what we have taken the project. We've done 8 cases. It's a thesis project of one of my postgraduates, and we find wonderful results with this technique, which is handling the distal pancreas. So the surgeon experience, I would say we have handled all kinds of cystogastrostomies, ramps. Spleen preserving is a challenging job doing laparoscopically. Laparoassisted pancreatic and totally laparoscopic pancreatic. We just had one mortality in this. And you can just see that this is a young girl. This is how at the end of the day. You can see MRI at the distal tail, there's a cyst adenoma. A specimen would be like this. And this is at the end an 18-year-old spleen preserving pancreatico-SC pancreatectomy is a challenging job done in very few centers. This is how at the end of the day the things look like. This is the distal pancreatico-splenectomy when the tumor is in. This is a monoblock specimen we have removed. This is at the end of the day how the picture looks like. You could see a tumor over there. Thank you, Umar sir, for giving that feedback, which made my life easy handling it laparoscopically. Again, salute. Thank you. This is how we do laparoscopic, totally laparoscopic, the whipples, what you call as, this is how the specimen will look like, and this is how at the end of the day, we handled it by and the department has a privilege to have done the laparoscopic, whipples. For last 3 years we are into this. And this is my channel. I would say that this is not a money minting machine. A lot of work has gone into this. 4,000 subscribers, 500 videos published. It is 15 years job, and I'm not earning any money. It is just my nights have gone into making this. This is for you people. I don't need claps, believe me. And at the end of the day, don't kick me for doing this job. Don't thank me also. But I would say that this is, keep on publishing, patenting. This is how you are recognized all across the globe. And thank you. Went around 12 countries now as a faculty, invited guest talks, innovations, patency and all that. This is how you people need to carry the show on. So I will just show you small videos just to tell you how. This is, you can see the pancreas down, stomach is hitched up. This is a gastric hitch, a Japanese way. You hitch it up, take the specimen. This is body here. This is the body. This is the head here in the C loop. So look at this, because pancreas is a fastidious organ. It's very vascular. So you just remove the body. This is a bipolar. It's a very tricky thing. PCNL needle is a good thing to hit the needle. But if you don't hit it, then you call Umar sir. He will tell you the way to hit it. So, but if you hit it, you get into the duct. A good duct size is very important to know. And then what is very important in this procedure, the chronic calcific pancreatitis, the guidelines have changed now. Probably the surgery is the last thing now. That is what Professor Kuru told me other day on the phone. Thank you, sir, for that enlightenment of giving me the guidelines you sent me on WhatsApp about the CCP. But we as surgeons, if the ducts have multiple stones, US is now the current modality, probably they are taking it from us. But there are indications where you need to do a wide ductotomy and clear the stones, dilate the stricture, and then make an anastomosis. You could see the whole duct is seen, all the pancreatic duct. What we do is we use biliary or vascular fogarty to remove these stones, and all gadgets are in the department. We have mechanical lithotrite, we have lasers, we have the shock waves, but we just handle with the vascular the biliary fogarty or a vascular fogarty to get these stones. That is what we do in distal stones in CPD also. We do it on our way. So the important thing is how to make the anastomosis. You need to be trained for that, for the intracorporeal suture. And it is same thing like a gastrojejunostomy. Nothing more about it. So the gills pesto, or you do a Gillsburg, and what's the other one? Gills big pesto is one, and the second is one more. We have done both the techniques laparoscopically. They are replicable. What you do in open, exactly you do it precisely. The blood loss is less, early recovery. Otherwise, it's the same way. We are doing the same job. Our roads are different. Our target is same. I think Balsab is there. He will tell me that we are doing the right job for the benefit of patient. Next day, our patient is up. Thankfully, our mortality morbidity, when we look at the literature, because I am doing an editor job and thankless job for 18 journals, and I keep on seeing these papers. Our mortality, and given the infrastructure, believe me, it is still low. I would not say it's excellent, but it is comparable, given the way we handle these. So this is how we do a pancreatic jejunostomy, a 4-layered anastomosis. It cannot be done by a stapler. That's an unfortunate part, but that's what the future looks for. If we have a stapler, just fire one, and Dr. Mubashir is here, you know that. You just fire a stapler and the job is done. But it will take time for the science to get into that. Then I would just say that this is what I showed about this. We took up somewhere, we did three cases total about distal pancreas, spleen preserving distal pancreas. So you know the Varsha technique, you know the Kimura. If you take the vessels, then you have probably jeopardized its spleen. 10% may develop necrosis, and next day you may probably land in doing a splenectomy. But this was a young girl. It's very important to preserve the spleen. It's 18-year-old girl. This was done outside the hospital, so totally it is a common mosque where we pray, whether out or in. We totally keep on doing this work. This girl came with us with a cyst adenoma at the tail of the pancreas. So what we do is in this, you can see the precision you go. That's the beauty about the laparoscopy. You precisely go to, don't handle many things. You can see the tumor here. This is pancreas, and this is the tail of pancreas that is housed in the, the hilum of the spleen. Now the idea is, I was partly in Japan. What they do is they do a lot of coaxial and techniques in the stomach. What you call as gastric lifting techniques. We learned from them. You preserve the ports. No need of making a port. Just put a suture, hitch it up. Your pancreas is all available to you. Just look at this, and this is the tumor. This is adenoma. Now, what is your aim? You will go to the inferior border at the junction, classically at the neck. You make an anti-clock, but first make sure that you expose the whole pancreas. And then come by anti-clockwise technique. Come by the splenic flexion. go all around down there. You can make it down all along the inferior border of the pancreas. I'll just make a little faster so that we cover a little bit of more. So I'm going along. You can see the precision, the blood loss. Now this is the tumor. I'm trying to separating it, getting the splenic flexion down. Just gauze is a sigh of relief. Every laparoscopic surgeon will know that. And here we are entering the lower border of the pancreas. Appreciate the beauty about the vision. That is my point. In open, you will struggle to see these structures. It's 20 times magnified. Thankfully, all appreciation to those who made these definition cameras. Can you see the splenic vein? It's an inferior to superior technique. And you're seeing all in. And appreciate how you are going at this part where the tunnel lies, the low tunnel. You're just on the left side of the low tunnel because your aim is only to take the body and the tail of pancreas. Now appreciate how precisely you go, seeing the structures. Can you see? You are going up, you're trying to fiddle, getting the vein down. The problem is that, hey, majority of patients, you have intracapsular splenic artery and splenic vein. Unless you will not do capsulotomy, you probably will hit this vein, and that's a disaster. Let me tell you. When you're getting into there, your idea is to get the pancreas up, hit it up, go below. Another worry is, if you are a little medial, you will hit the CHA. I asked Keynote, what if you hit CHA? He said, please don't ask me this question. So I understood what he meant. So you're going superiorly, so you have to understand it's a snaky path. Anatomy has to be very clear before you venture in this. This is the coronary vein, left gastric vein. The idea is to make a retropancreatic tunnel, and then you will preserve the splenic arteries and leave them behind. But here we have to preserve. Because we have to preserve the spleen, so we will preserve. We will go by a Kimura technique. Otherwise, you can take the vessels and leave it to gastrosplenic vesicle, but 10% of people might land into a splenic infarction, and then you may probably have to go for splenectomy in these patients. So beauty about this is, but technically challenging, yes, I agree, but it needs a lot of precision to go. You can see the whole splenic vein. Now, how to separate it from the parenchyma of this? Now you can appreciate the vein there, looking very tortuous there. That is the worry of the surgeon. He has to be very precise. Your movements have to be very precise when you're handling this kind of job. And when you see, you have to separate this vein all along the body, going to the tail to the spleen, and making sure that you don't injure this vasculature, because otherwise then you may land into splenectomy. So this young girl, we need to preserve the spleen. That should be the attitude. Now you can appreciate how we are going to separate the artery, splenic artery. Now we are hooking the pancreas. Pancreas is almost up body, and the best way to do is put a sling and hold the sling in your left hand so that you can make the job easy. You can fire a stapler and transect the pancreas. So this is how you go along, and I should say this is how we fire. As a brown cartridge would be enough, but black would be better. Tri-staple, try to use. But if you are using this kind of cartridge, then probably stay for 5 to 10 minutes. Compression time is very important. So I should say that we are separating the splenic artery, splenic vein. You can see now at the end of the day, we have preserved the spleen for this angle. The tumor is taken from the body and the tail, and just putting making clean. And you can see the vessels here. Splenic artery, splenic vein, you can preserve, and you can see the color of spleen should be checked, and then left it to the God. The rest is in his hands. Remove the specimen and call it a day. So we go to the next. Next video would be about lab ramps. Now ramps is the thesis. We did 8 cases, and alhamdulillah, no mortality, no morbidity. They're all doing well. Ramps is done for the distal tumors. Professor Umar is here, has handled quite a bit of these patients. So when we are in trouble, we call him, and he is at a hand. Thank you, sir, for coming. I think last week you came, and he completed. We could not hit in one of patients the pancreatic. He comes and makes the job easy. Changing the road and getting it done. So I will not go to the ports and all that. I'll just concentrate on what we do. So this is how we go in the abdomen, doing a diagnostic laparoscopy, again holding the stomach up by a gastric hitch, opening the gastrocolic ligament. Can you see the tumor here? This is a net. Net is very common in the distal pancreas, neuroendocrine tumors. They are very bad tumors if the histology is very poor. But the ramps is, that's why ramps collectively takes good care of suprapancreatic, retropancreatic nodes, and takes care of the tumors also. So it's both good for benign and the. So now please see, this is our way of taking the stitch. Don't call it a Chalku technique, please. This is anybody's technique, but how to do the hitch? We are taking whole stomach in a single go. We have our own rolling technique. We again published. What we do is in bariatric surgery, you will find when you go to the up to the stomach, it's difficult. It rolls down. It creates confusions to them. So you roll it over the grasper. We have published that as our technique. So here, this gastric stitch, which I am saying, it saves ports. You put the structures up, and then the idea is to create dissect the mesocolon, take it down, again going back. Here you have no worry, you have to take the splenic artery, go to the splenic hilum, dissect the planes. Now you can see the tumor. Important is do not injure the vasculature at spleen. One should do the, now question is, should we go for a CT angio to see whether it's a distributory pattern or a magisterial? Yes, you should discuss it with a radiologist. The road is very clear if you know the anatomy, otherwise you will land into troubles. And it's very difficult to go to that place by opening technique. It will take a lot of time to reach there. By that time, patient will be in shock. Know what you are doing. So, and you should have a clear concept. Discuss it, the radiology, imaging with your colleague in the radiology department. You can see now we are separating the splenic vein. This is the superior border of the pancreas. I am getting into the pancreas, and see what we do is that we are put a fire. We have stepped the part of this pancreas going up. Now another firing. The worry is that you should not take CHA. If you cut the CHA, probably you know. I don't know the answer. I have not even talked to many people. There is plus minus. Literature is also silent about it. Some say there will be a necrosis of liver. Some say no. There is some collateral. It takes time. I mean, there's a very bizarre, literature about that. So, but in the first go, I should say, please don't do that. Be cautious what you are doing, because one simple mistake would mean catastrophe. So you can see the artery and you can see the vein. First, you should take the artery, then take the vein. So that's the principle. Otherwise, spleen will become congested. So you can see they are clipped, artery and vein, and I'm taking it as a monoblock. I'll go to the spleen now. I'll go to the spleen, take it all along, graping and gratting, gadding along the vessel. I'll go, and this is another fire. Sometimes you may need 2 to 3 fires depending on the amount of pancreas available to you. Then we are taking it out, and this is how we do it at the end of the day. It is a hippie situation. Pancreas and spleen is in your hands. And the pictures, I know this is a monoblock specimen, this body, tail, pancreas, all in a go. So at the end of the day, this is how the patient would look like. And then the last of the list, it would be doing a Whipple's kind of procedure, or you can say modified Whipple's pylorus preserving type. So how we do that is that one of my postgraduates recently had an award there for this video, and I will just go hurriedly for this video, not take much time. I hope I have some time. This is the last video. So I'm going for Whipple's. This is the vascular, how we go. Again the same ports will not matter. Make the retroduodenal tunnel, go to that area, make sure that your first part of is mobilized first. Then you can appreciate we are going up, mobilizing the duodenum. Now you have to transect the duodenum. Start by transecting the duodenum. Pancreas is available to you. You are going superiorly. This is IVC down. This is IVC down. So understand the anatomy, and aorta will be again close to it. You have to do extended cauterization. That is the art in this Whipple's. This is GDA, gastroduodenal. You can see the gastroduodenal, how we are clipping it. It's very simple to identify it. If you know the anatomy on the camel's hump, you go down, you just clip the vessel, just fire it, cauterize it, the job is done. And then as you go down, you need to understand where is the love tunnel. Before you are loved badly, you need to understand it. Pull out this. This is the right colic vein. You should know GST, gastrocolic trunk, the anatomy you know, and then ligate them all vessels. Otherwise, this is a torrential bleeding. So the anatomy at this part has to be, and there are very variations. Understand, this is our technique. You have Umar's technique, you have Chalku technique also. So we replicate this technique by using a needle holder. This is very simple to move. You are exactly on the portal vein, but you should know how to handle this. Fingering and using the instrument is the art. It comes with time and experience. Just fire it there. Go up superiorly. You are here now. What I am trying to show is that you cut the. This is what is important to understand. This procedure we finish it in just 5 hours. Laparoscopic ripples. So you can see this is the aorta and this is the IVC on that, and this is the second part of duodenum. So you are doing an extended cauterization. The art is, if you go by extended cauterization, your job is done. Then you go to the jejunal veins down there, go to the third part, lift it up, but don't get the jejunum which you have cut 10 centimeters distal to the GJ, gastroduodenal junction. Pull it out through to your right side of the patient. You can just see, you're just taking the paraduodenal fascia down. You are just getting into this plane precisely. Look at the blood loss. Believe me, there's not much of editing with this video. Look at the blood loss. Get the jejunum down. Now the whole specimen of first, second, third part and the jejunum is with you on the right side. Now you transect the pancreas. Don't put a stapler because you have to identify the duct. So cut it with, you can see the duct. Now you will meet the duct. There are a lot of anomalies of this duct. But if it is a good duct, then your job is easy. But if it is a small duct, then you will have probably do a dunking technique to do a pancreatic gastrostomy or something like that. So that is your good luck, how the duct is like there. So you can see the typical problem is that CHD is cut. Now this is the uncinate process. Most difficult part of this procedure is uncinate process because it's like posterior to this SME photo. Dr. Goja is here. Sir, please, this is our humble way. We are trying to do it, and we are just pulling the this thing uncinate process down. CHD is ligated. Don't leave it unligated because it will sip the whole the bile into the peritoneal cavity. Then we are making a pancreatic jejunostomy. A difficult first anastomosis. A difficult if the duct is small, but you can put a stent and do a. There are many techniques. A Blumgott way, you go by dunking technique. There are a lot of techniques, but whatever you find feasible is important. But putting a stent is also a sigh of relief. Then HJ, it takes us just 20 minutes to make HJ. We are into making hepatic jejunos for long. It just takes us 20 minutes. And then at the end, we do a GJ, gastrojejunostomy. It completes all the 3 anastomosis. And alhamdulillah, patient is up and up. And then do a FJ also, feeding jejunostomy. You may have to early report to the feeding. And this completes the procedure of, this is how the specimen looks like, and this is how the patient looks like. Thank you very much. I think I have done justice with the time. If there are any questions, I can take later.
Thank you, Professor Chalku, for your wonderful demonstration, and the pancreatectomy. It was nice to see the people as much as doing in a nice way. So let us conclude the session, and if there are any questions, you are welcome to. Okay, it will be at the end of the session.
We'd like to end this session with a video message by Professor P. Jagatnath, ex-president IHPBA.
All the colleagues in Kashmir, I wish you the best. Greetings to all the colleagues in Kashmir. I wish I was there personally. I love Kashmir and your warmth and your culture. In 2009, Umar invited me to bring the chapter of the IHPBA to Kashmir. I was here in Srinagar. On the previous day evening, he suddenly tells me that sir, tomorrow you'll give an oration. Frankly, I was not prepared. I just looked around and found this amazing natural beauty in Kashmir. I spoke extempore without any of the slides and just nature and how it influences our journey through a surgeon's life. Professor Kuru was in chair and you were kind enough to give me a standing ovation. I emphasized on that day and now the medicine and music know no boundaries, and that is the reason why I am very, very close to development of HPB surgery in Kashmir. My visit to Kashmir to initiate HPB surgery started then, and it was a transformative journey to find that you are really taking it forward as a specialized care for your patients. Ultimately, we need to give the best possible care for the patient. One of the important things which is needed for that is an ongoing professional education and collaboration. If we have an established regular case discussions, virtual meetings, expert opinions, we'll make sure that our patients get the best care. Our knowledge is constantly improving and you need to stay up to date. All this can be done as you are part of a much larger organization which we are all going to help and build and make sure that your needs are taken care to provide the highest quality of HPB surgery for your patients so that they don't need to go anywhere and will be taken care of you. Today, as you meet, I really wish you all success. But let us make a commitment saying that we are going to establish a shared community of people who are willing to participate, engage you, and in patient care as well as in continuing interaction and education. Wish you all the best once again.
Now it's time for our second session, and I request Professor Dr. M.S. Khuru, Professor Dr. Nazir Ahmed Sabru, Professor Dr. Ejaz Malik, and Professor Dr. Abdul Rashid Ganai to kindly chair the session. Thank you.
Good evening, everybody, and Assalamu alaikum. We're very, very proud to have a very distinguished speaker, Dr. Sanjay Godia. He's a son of the soil and one of the leading liver transplant surgeons of the country. He not only operates in Delhi, but he operates all over the country. And I'm sure he probably operates outside the country also. So Dr. Sanjay will speak on vascular resection and reconstruction of hepatobiliary and pancreatic surgery. And we're very proud to have him here to speak on that topic.
nice to be here and meeting all the people. I know before and some people I met today. Amazing work. When I was coming from the airport, the guy who brought me here, senior resident, I was asking him what sort of work here. I was totally, I couldn't believe it. And now seeing all the videos, I think it is unbelievable. I mean, really amazing work. I mean, I'm not much in the laparoscopic surgery, although I did first robotic pedectomy in India, that I got published it. Robotic I started, but probably I was not good at laparoscopic surgery. I did laparoscopic cholecystectomy, then I went into core GI. Okay, then you are out of track. Okay, but looking at the suturing in this pancreatic surgery, unbelievable. I mean, commendable. How do you move this slide next? So I will go straight away to my presentation, vascular resections and reconstructions in HPB surgery. Okay, this one. So I will just, it will be more of a photo session only, and I had some videos, but unfortunately some of the videos, one of the main video is not working, but still I put some photos there. So I will start with the pancreas, your topic only. So when do we need vascular resections in the pancreas? Essentially, when we talk of the pancreas, we are looking at one group of the patients where the vascular resection is needed. That is borderline resectable patients. It is the group which we have to do, whether they need new adjuvant or you can go straight away to, there are differences in guidelines or all that. So what that actually means is two vessels we have to look at. One is veins and arteries. It's a SMV, portal vein and artery. So portal vein, most of the people who are in the vascular resection, this is not a big deal. You can put a graft, I will show one, you can put together. Artery, we have to be very careful. Doing artery is easier. Doing portal vein, because small kinks, small missuturing will cause thrombosis. It will not work. Artery always works, it is easier to do. But unfortunately, for the prognostic point of view, it is the other way around. If the artery is involved, I mean the goose is cooked. I mean, so you have to be careful selecting the patient whom you would. The problem with the transplant surgeons is they do resections rather they think everything can be done for the sake of doing it. But we have to be very careful. So when you get some neurogen, how do you assess? We all assess cancer by the imaging, and we have this when we have involvement of vein and artery. Essentially, it is cut off of 180 degrees or more than 180 degrees. In vein, it is more. Even if it is more than 100, it is resectable. Even if the splenic vein is it is resectable, you can put the graft. But artery, if it is more than 180 and it is not a resectable, and sometimes you do neoadjuvant. But when it is in the vein, you will thrombus, you are selecting for the neoadjuvant. What should we look at? Is it the patient's overall condition? Is it the radiological improvement? Is it the tumor markers? So if the new guideline is the patient is stable and CA99 is stable, even if the tumor stays same, go for the resection. That is one. You don't look that tumor has decreased in size at here. This is a nivel. So it all makes sense only if it improves the survival. If we look at all these graphs, if you are doing vascular resection and not doing vascular, there is not much of the difference between the survival. The vascular resection is not a provided you are doing R0 resection and the resection is complete. And if you compare in the third of the graph, if you compare to who are giving the bypass surgery, the prognosis, we have to make sure that SMV drains well. If it is not draining well, if there is sliding, it is not going to work no matter what you do. These are some of the photos, and one of the interesting thing is when you do, if it is very hard tumor and vessel involvement, they don't do well. Who do well with the vascular resection? Who have partially cystic components? This is one of the, I did very big tumor. If you see that veins, they're all dilated down and it is all stuck there. But when you take out, you join the ends together and it looks beautiful after that. What is most important, I put this photo, is when it is stretched and you release it.
There's all, because when you cut never get scared that you need always interposition. There's hardly ever you need an interposition graft, because if you release liver from the top, liver will come down, the space will get lesser, and there's no need for the graft. And make sure it is not tight. It's not very stretched. No, vein will never work if it is stretched. It has to be little laxity. So that is why a full stretch is like this. Then when we release, it has come here. So this is about pancreas, breast, all the things they are taught. About the liver, the second class where we do hepatobiliary surgery is cholangiocarcinoma, hilar cholangiocarcinomas. Why do we need, we frequently need vascular resection in cholangiocarcinomas? Because of all intricate anatomy about in the hilum. It is all jumbled up in the air. And they involve usually the portal vein. They are very fibrotic tumors, and there is encasement of portal vein, and you have to resect. And it has a direct correlation with the stage. We do cholangiocarcinoma bismuth classification. As you increase the classification of the bismuth classification, no matter what you see in the CT scan or MRI imaging, if it is 3 or 4 stage, it is better to resect the portal vein. Dr. Umar will agree. There's one German guy who doesn't believe in doing at all removing that. He just cuts the hilum and reanastomoses that. So when we mobilize, it looks like this. It's all hitched up towards and never ever try to dissect around that fibrous tissue thinking that is a fibrous tissue. It is a malignancy. It is a malignancy, and you have to resect it. So does that help if we do resection of portal vein in hilar cholangiocarcinomas? The godfather of hilar cholangiocarcinoma, everybody will agree, is Nimura, and that we all looked to him. And fortunately, I was fortunate to have a meeting with him. I discussed some things about it. I was very impressed the way he told me. Before they published that lymph node, before that we used to think that if there's lymph node involvement, hilar colon, don't operate. He told me that we are investigating it, and you go ahead with the lymph node dissection and all that. This paper, 2000 classical paper which came, essentially it boils hepatectomy with vascular resection, portal vein or hepatic artery is technically demanding. And it has mortality and morbidity. There's no doubt about that. Even in our cases, there is a mortality and morbidity. The survival is not that good, which is in the normal resection. They are inferior to without vascular resection, but they are much better than if you don't resect. So 1, 3, and 5 survival rate is nearly, it comes to around 30 to 40%. Okay, and that is good enough, and so offers a good survival benefit in a selected patients. I had a video of this. Unfortunately, that didn't work, but luckily I had photos of this. So I will just track the crux of when we do portal vein resection, what needs to be looked at. It's not just you cut, because it is angle. It goes towards the right and then move it. So even how much taut that should be, how much angulation it should be, that matters. Otherwise, it's not going to work. The putting of the clamps and direction of the clamps is important. That is most important. And do you mark here? Pointer, sorry. Pointer. Pointer, please. Sorry, pointer. Okay. Just I want to tell all the what we want to look at. That's why I put this video. Yeah. You see, if you see this clamp, this is totally vertical. You have to make sure that they are anterior to posterior here. They are anterior to posterior. Okay. Then when you cut it, make sure don't cut too much. Okay. Then make sure when you are cutting, you have to look inside that it is a smooth inside endothelium, because the cholangiocarcinomas have a propensity of
thought, can we go out of it? Can we help our population? Can we not resect these livers? Can we do something more? Doing what every person in laparoscopy starts first. He starts dissecting the calloid strangle. Of course, here we are just taking care of the artery. We make sure that the duct stays there because this is going to help us in the dissection. And you can see the bluish structure. I'm sure Professor Kuru is just observing this bluish structure. And what we are now, what is coming here? It is what Dr. Gojar talked about, the portal vein. Now imagine where it is. It is hugging the CBD. It is hugging the dilated CBD. And now we have gone across this. And this is a vascular sling. We surgeons are very good at imitating people, at understanding what is good for us, and we take it for every specialty. Now what we never thought of doing, I'm cutting the CBD, I'm transecting it. Why am I doing it? Because I want to go into the liver. And what I'm doing now is, this is the lower end of the cut end of the CBD. Very simple suturing. Since the advent of braided sutures, things have changed. Outlook for laparoscopic suturing has changed. And now this, can you see the hilum? And what are you seeing now? You're going into the liver, sir. So you're going into the secondary ducts. And with what are we doing it? I'll be showing it very soon. So after that, now what is this? This is the DJ flexure. So around 35-40 centimeters. Just a simple trick. Lift the jejunum up, go into the mesentery, dissect it, and what the J&J people and what the Covidian people have done for us, they have given us these staplers, a blue load, fire it across, and your roux loop is ready. We are doing a Roux-en-Y hepaticojejunostomy, but we don't do it in front of the colon. We're not happy with that now. So what we do, we open the mesentery of the colon. Slightly messy because the vascularity is there. And then we take this colon, we take this jejunum up because it's hepaticojejunostomy. Now it's going into the supracolic compartment. We do not want to have any stress on our anastomosis. L-hook, we have all the gadgets Professor Chalko already talked about, but simple things can be used and should be used, and that's my message to the youngsters, that you should not feel uncomfortable if you do not have everything. And then, as you can see, very simple steps, because it's a magnified view, you can do the anastomosis in a very quick time, very fast time, especially with the use of these braided sutures. Then cut it. Of course, do not forget that you have to hitch it. That will reduce the tension on an anastomosis. And the number 2 step is that you have to make sure that you close the hole in the mesocolon that you have made. Otherwise, what is going to happen? Yes, and my youngsters, my registrars, they recently operated a very good case of retrograde intersusception. There was gangrene. It was one of the best cases. I saw them operating and patient went home. And then, juj, doesn't take much time. Just bring the 2 loops together. Make them stable. In laparoscopy, the problem is that your hands are away. So you must make sure that everything is stable. Once your hands are stable, your instruments are stable, then anastomosis is okay. I won't say that it comes easily. It takes some time. Please bear with that. Even if you do FNB, as my colleagues are doing here, even after that, it will take some time. You have to be patient. It's not going to happen in a day. And here what we are doing, we are burying the first layer. Just an additional feature sometimes that we use, and sometimes we don't use, depending upon what we feel. An additional clip at the end of the procedure. And then, of course, should we keep the gallbladder there? No, of course we have to remove it. And this is the first case that is done by most of the laparoscopic surgeons. Okay, what is this beautiful equipment that I have in hand now? I am moving it like a snake. Okay, so now I have got the urologist out of his nice chamber and I have a video there. The screen is in front. I am not using a kaleidoscope. I am using this small instrument, and it's going in, and it's giving me the view of inside. See the magnification. Where am I going? I'm going higher up, as high as possible. And now, instead of the cystoscope, we have started using the flexible nephroscope, and that is going into the smallest part. And now something that I'm sure Dr. Jal, where is he? He's going to hate me. I'm using his laser, and we are lasing the stones in the hepatic ducts. We are lasing the stones in the hepatic ducts, where we would have to resect the liver. That is being taken care of by these equipments that have come, thanks to whoever was the person who made them and who got them here. I think we must thank our government that they have made these things available in the private sector, in the public sector. Now see the clarity, see the vision, see, it's really beautiful. Okay, so can we go out of this video? Okay, out of this video. So that is my team. They are a wonderful bunch of guys and gals, I can call them. Rifat is not here, but most of them are here. And we are a diverse group, we are a social group, we are a socialist group, and we are a republic group. And I hope that you will pray for us that we will do something better even than what we are doing today. Thank you very much.
I think we're very proud to. This demonstration is particularly one that we're very proud that you're doing such brilliant work actually for hepatodetection, treating it by an innovative technique. Although the technique across sphincters, there are excellent to do the hand spike and also the laser. But doing it here in an innovative way, excellent visualization by that.
Thank you, sir. Thank you very much.
Everybody.
It was a wonderful presentation. Our next presenter is none other than one of our teachers. The next presenter is one of our teachers, Dr. Umar Javed Shah sir. He will give a talk on journey in pancreatic surgery. Dr. Umar sir, please.
Thank you very much. And, thank you for coming around from your homes tonight. And, I must pay my due respects to my very senior colleagues who have seen, I have rather seen them from their youth to different phases of life when I was very young. And especially Professor Khuru, Professor Shaukat Zardan, Professor Nazir Sandhu, Nisar, and all other stalwarts here who have gathered here, and especially respects to Sanjay Guja, whom I love because of his qualities. He is a good human being, that's the finality, and that's how he is attached, and the purpose is that. And I love to be here today because they forced me to speak after many, many years. And I will be speaking, they have asked me to speak on a subject which is vast. They told me you speak, and it's very difficult for me to speak in a very short span of time. So I try to be precise, very focused, and try to complete what I want to complete. Thank you, sir. This gathering is basically focused for the younger generation to build their thought process. And I am rather at that age now where I feel this process of thinking springs out from some of the youngsters who carry on the job. That's what I saw in this the medical college where I'm back to school after my tenure was over at SKIMS. It spanned over more than 3.5 decades. And that's a bit, time, and I have not gone anywhere in between. So I spent a lot of time there. So you must think big always. I will tell you one thing, think big, dream big, and believe big. And the results will be certainly, inshallah, big. This is as a young man, you must think like that. This is what I used to think. And then I have seen the process, pre, intra, post, in my lifetime, whatever I have had a tenure as an active surgeon. I think this man has been very instrumental in shaping that system. I am not at that age and at a status of life where I try to appease people. No, I am not an appease. I really mean that we have had a conflict also in between us. Between he and me, we only two know why it happened. But I think he is the person who guided my journey there at SKIMS. I really admire him. Although we lost him young, but he was a fantastic surgeon, let me tell you one thing. I used to love watching him, assisting him. Professor Peer is here. I assisted him for 17 years. And at the faculty, when I was an associate professor, he told me, now you go and develop your own way. Because of something. I told him, no, I will still try to assist you. He said, no, I may not be here after some time. So you try to develop your own life. It was a bit hard, but that was the way you have to build up your life. And the only thing which I think brings a thought process in you is challenge yourself. And the greatest example I will tell you here is Professor Kuru, Professor Shaukat. This is what I can see, without any, I am not, why should I do that? But this is what is real life. I have seen them challenging themselves. They are stalwarts. And they have contributed, and we are lucky to have them. And we must respect them. We must give them love. We must give them, respect. They should be all the time interact with the juniors. They must. You should be lucky to interact with such senior fellows so that they build your thought process. And that's what happens in life. I was very fortunate. Once I was in a troubled time, everybody passes through troubled times. Otherwise, you are not going to go on the correct track. I think this man, he was my mentor. There's no doubt about it. He got introduced, or rather I got introduced to him somewhere back in 2004. Believe me, he kept going on with me till 2014. And he would interact with me, numerous letters, numerous emails with me, which my only immediate family knows about it. I can share, once the time comes, I can share some of the letters with you. That's what I say. He was so enthusiastic. Once I was designing the splenorenal shunt at SKIMS, which was a challenge. In 1999, I must give credit to Dr. Shaukat there, where I stopped. They told me, you go out. You have to do portal hypertension. And that was a challenge for me. I went out. I started learning portal hypertension for a few months. But once I came back, Fayaz Khan was with me. My friend, he was my senior resident. And he operated the first line renal stent in March 2000.
So I was the PG.
Yeah, you were the PG. This is so wonderful to have you. And this man Shaukat Zalgar put me in a blood bath. I said to myself that I am using 16, 17 units of blood on a patient, and in this atmosphere, which is all round very uncomfortable from circumstances, how these patients are surviving. I will have a tough time with them. So it took many years for reaching to a method which finally I was very fortunate to delve and understand the technical values of that, what happens where, what Sanjay was telling about the kicks and kinks and other things. That's what kills a surgeon. And the process of success is, fades away with those small mistakes which the world has understood over hundreds of years. And it is not a small thing. So once you are designing something at a world-class level, think always that this person has gone beyond his time. And once somebody of authority, a legend, testifies it, that means it is the correct thing. That's exactly what happened. Spleno shunt went all around the globe, all continents in world, which I had sent. They rejected it because of some reason or the some, except there's a great surgeon called Lytle Rickers, who was Annals of Surgery. He was the editor-in-chief. He was a great portal hypertension. He had remarked it well. That kept me going for another year. And after that, I told myself it's not going to go. It was 3 years old, paper with me. So finally, I said it must go to the person who is doing it. And this is the person who is doing it. This is the person who was doing vascular surgery. But he was the best person because he had done a lot of cases in life. And he propagated it. He got it published in his journal. And he named it. I didn't name. Some of the colleagues know about it. I told them I don't want. He named. He said no. And he names that shunt after me. Which is, I don't want to, be me or I or this is what world is like. So he is my mentor. And most of us know about it. Whole world knows about him. And we lost him sometime back in 2016. The last letter I received from him was in 2014. So he is a legend and nothing needs to be further mentioned about him. We know about him and I just skip around. And finally he had a very, very difficult time with his senior colleague, Michael DeBakey. Michael DeBakey, you know yourself, is a great vascular surgeon. But finally he awarded him from his own dental colleague, what you call it as association. They compromised at the end. And this is his institution where he does his own. This is his private institution. He owns this institution. He owned rather. In 2016 he passed away. And this was the portal hypertension shunt which we discovered. And this is the letter what he mentioned. This was the last letter which he wrote to me somewhere in June 2014. He named this shunt as Umar shunt. I was surprised. And this was a very wonderful letter to me from him. Anyway, the only thing what I want to say is that portal hypertension became a true fact at Skills. It became a high volume portal hypertension surgical unit in the country. And where we had completed more than 2005, the surgical gastroenterology inception was there. Before that, we had completed more than 70 shunts. And that was not a joke. Dr. Shaukat knows about it. They used to send the patients. We used to operate. We mastered the technique. There's no doubt about it. We never lost the patient. We got almost nearing 90%, functional shunts till the last follow-up we had. Of course, the disease faded away somewhere from 2008, 2009. Less patients came back. But the last patient I operated at Skims, once I left, was in November 2021, was a 16-year-old girl, which I operated. I was so happy to do it. Perfect. I had completed more than 130 odd shunts that time. I was so delighted as a surgeon to have completed this last procedure. And we get this patient, their babies. I have operated 3-year-old child. They are now adults. Some of them have families, and that's the pleasure. The only thing what I want to tell the youngsters and the seniors, make a team. Make a team. Get together. This is the most important thing once we advance in any subject. If you have a good, dedicated team, this is there. And if you're a hard-working guy means if you're honest to your own soul, you will certainly find luck there. And this was the institution where I started my pancreatic surgery, because I want to give tribute to her, Dr. Wani. And before that, Professor Mahmoud Khan, she did some procedures like that, though I was not present there at that time. I was first time a student. And Professor B.K. Jalali, I remember he did one pancreatic duodenectomy. There was a big news in medical college, of course, that time. And then it was Professor Wani, who came back from England in '83. He started doing pancreatic surgery, which Professor Kuru must be knowing very well. He was a very good pancreatic surgeon. And that time, initial part of his was, he was very well adapted to the pancreatic duodenectomy. Of course, he faded away from 90 onwards. The pancreatic duodenectomy was less within his hands, but the situation was not good. But he would continue doing pancreatic duodenostomies, and he was an expert in this. I was very fortunate to have been attached with him, and I learned my basic trainings from him. And that is how the process started at SCIMS. I strongly believe and trust that the river cuts through a rock, not because of its power. It is because of the persistence it cuts through. Remember what I am saying. And what better example than Whipple himself. We know in 1935, he failed. He did one stage, two-stage procedure in such a patient. And in 1938, he ligated the pancreatic duct. Again, patient died. Then it was 1945, 10 years of persistence. And it was the year earlier to Michael Hendricks had discovered vitamin K in Europe, and that got transferred to America. And Whipple's did the first one-stage procedure, which is named after him, Whipple's. Although it was Alfred Koch, 1908, a German surgeon, who did the first Whipple's in 1908. So it is sometimes called it Alfred Koch Whipple operation. That is rightly called. But it is this Whipple who popularized Whipple all over the world. He was a great, great surgeon and a philanthropist. He continued to do that, and the world saw huge difference of morbidity and mortality, from nihilism to positivity. And the mortality in the best center like Cameron, who spent most of his life doing Whipples, has come down to around 1.6% in his study in 2015. So that was a huge leap. But that was only possible of the management, pre-operative, intraoperative, post-operative management of this patient. And not to talk of a team, which is so vital in this, which is a multidisciplinary team. As you can see, the development of the team is the most important successful point if you want to be a successful pancreatic surgeon. In fact, all surgeries, you got to have a good team, dedicated team. Then you got to have a good leader, like I would say here in this audience, like Professor Kuru, Professor Shaukat Zakar. They used to lead their teams. They used to come to general surgery that time. General surgery was not general surgery like SMHs. No. Because I had seen both. In fact, I came back to 90 to medical college. I was a lecturer there for 2.5 years. 2 years registrar. General surgery at SCIMS was different. It was surgical gastroenterology that time. And now the trend is different. This is what I want to tell you. Because of the leaders, you had Professor Nazirwani, Professor Kuru, because they were so scientifically oriented, they would get the message. They would get to the work early morning and find out till evening. I still remember Professor Shaukat Zakar. He told Dr. Thusu was there. They had a patient upstairs in Ward 5. His fever was not coming down. He told him they're giving this drug, and then his temperature will come down. The 15 days, no temperature was not coming down in medicine ward. Then early morning, I heard him speaking to him. I went to the Ward 5, and I saw that patient had no fever that day. That was malignancy, fever induced. And he told me this drug is only for that. This is experience. This is why we have to seniors lead to our juniors. And we should be happy in seeing the juniors doing well. Leave the interpersonal conflicts. See the purpose of life. See what for you are born. You will get a good reward in this world, I assure you. Inshallah. The Department of Surgical Gastroenterology did its inception in 2003. It came out of a lot of struggle. Lot of struggle. You can imagine today. It was, I think, Professor Khuru was out that time. Professor Shaukat Zargar. He had put me in practice in 1999 for portal hypertension. And then long, it matured. He was heading so many committees. And I must give credit here to Professor Meraj. So he called the inception, gave the strength of the department, gave the beds to the department, although it was under general surgery, but then it was Dr. Jalal. More than every day his patients trickled down to our department. There's no doubt on that. Persistently, I still remember, I have the data with me, more than 80 cases of phrase I have done his patients on here. The data is with me. And look at the people who have made the department. And I give salute to these great people today. And today I am out of the department, but I am within the department. I am myself a department because my heart is full of department. And that's what happens to us. I am with you, that's what it is finally.
But part of that heart is with us also now.
Yes, and it was in 2012, that's what I meant. 2012 we started the super specialty course. I gave degrees to people, 18 people, all over India received degree. Professor Nandi, because I had passed through that phase with these talents. He told me, Dr. Shaukat Zargar was the director. He told me, don't do too much with him, he's a very cranky man. So I told somebody that he is very cranky, let me be away from him. But the person told me, you go and receive him at the airport. So that's how it happened. He came and straight away gave 2 seats of DNBC. That's how the department developed. And once it was faggot of the career, 2003, I wanted to now go out. I started for MCH and the MCH started there. And look at the work, this is my personal work. Right from, you will say, 94. Look at that work. I am amazed to see today. This was long back collected. And look at the pancreatic adenoectomies. It is 290. And now if you add up US, I don't know. Then look at the CBD injuries. And this was the reason. Reason was people didn't allow me to get into laparoscopy. Understand, I was doing complications. Professor Shaukat is here. He knows all 2 to 3 patients every day to my unit. And I was only repairing CBD injuries. And Professor Salru is here. Ask him. If I am wrong, he will testify it. I even went to his unit a few times to do it there. And that's why I'm not a leper. Don't blame me why I'm not a leper.
You're not blaming you.
I thought. So, this is the way it has been like with me. But I tell you, it is the necessity, is the mother of all inventions. Need does everything. And there comes the innovative technique of why so many pancreatic adenoectomies, innovative techniques came. Why did it come? I was begging for an operation theater for the specialty, Dr. Hamid Zardar. I wish he was here. He was showing a cold shoulder. I told him, how can I do these cases? He told me, no, he used to smile and keep a tape recorder on. I told him, why are you doing this? I am young, I have to complete my work in this world. But there was no, I still think that they don't have an operation theater of their own. I took a pledge with myself that I disclosed it in the auditorium once. I told them, I'm not going to leave this pancreas. I will show you what I'm going to do with it. And that's exactly what happened. This technique was bought. One day, out of frustration, I'm entering the library. I am seeing John Cameron's. There was a journal called a Surgery, and this was a short report by Cameron. And I thought that we will do it like this. Why? Dreaming. You have to dream. Once you dream, you can understand what you are doing. Then you apply, it comes, results come. And that's how this peer approach technique. This is a world famous technique. And now we are following up these patients. Some of the patients are having so long follow-up. Believe me, I am really thrilled to see the follow-up of these patients. And the reasons will come up soon in the literature. And you know how, you can go and read about it. I don't need to discuss this. But the unit which was there, it saw from a low to a high volume sector. I did my first papers with Dr. Ejaz was my assistant. Ejaz Malik, 1997. Dr. Wani and Dr. Merhai Saab had gone for a conference together. So Dr. Peer is here, yes. He was operating in the other theater. He was heading the department. So he told me, be very slow, be very slow. I told him, please, relax or I'm going to do. We completed first papers independently, 1997. And the story started then in surgical GE. The volume went up. And it was because of this technique we could produce this low volume to a high volume unit. And the descriptions are there. You got to read about it. You can note it down. Look at this. Look at this leap here. This is 2007. And look at this leap. 2010 onwards. 34 in a year, 32, 37, 33, 42, 47. Although I left the data here, I didn't make more bars. I will have to again go for some scrutiny of that. This was because of the technique. I used to do 2 whipples a day. I used to leave at 3:45. Nobody used to suffer. You can. I wish there was an anesthetist from my unit. They can testify that. You can ask them. So that was the speed. That was the accuracy we had. I had 18 theses of pancreas of DNB students. 18 theses written on pancreas only. So that means I must have seen each and everything which has been described in literature. I have seen all vascular anomalies, all ductal anomalies, everything which has been described, even unification of portal vein I have been seeing and doing and continuously monitoring. So that was the thing, this made the difference. And I don't need to talk about it because the time is short. And this is normal description, most of them are adenocarcinoma, ampullary next, distal cholangiocarcinoma, and the differences. Demographics didn't mature from low to medium to high, not much of a statistical difference, but classical, we changed various techniques on the way, becoming a high volume center, but the main thing was the duration of surgery was reduced. And this was highly statistically significant. Similar observation was in operative blood loss, requirement of blood transfusion, very statistically high. Fistula rate patients only. This is marvelous, what you call the description. That means technically you are 100% doing the thing what you are supposed to do. I have shared these results with some of the European friends and even in fact with Shali Shirkande and Professor Jagannath. And they really know this is very low incidence of pancreatic fistula with us. My professor, Professor Peer, will testify for that. He has been seeing all the patients in the ward. My gastroenterology people will testify for that. So that sort of story has come out from here. I don't want to talk about it right now. And again, centralization coupled with fast track recovery was another thesis, and we did this study. Within 8 post-operative days, patient was back home. And this is the protocol we used, for post-operative, pre-operative and post-operative management of these patients. But it was the hub-and-spoke phenomenon. Let me be very frank here. We depended on people to send the patients, but it was the district hospitals which helped us. District hospitals, we got director of health into contact, we got the telephone numbers. And the best part was mobile was available. They could send the patients, contact with us, and that is how the department developed into a very big department. It became a very high volume center of pancreatic surgery in India. Of course, there are hurdles. within the government, health sector, patient hurdles, that will carry on. That story carries on in life. And a lot of publications came in that area, and you can see some of the modifications which we did, and most of the work is published in these books. All famous books of the world, even Bloomgart and everywhere. This is for the youngsters, I'm saying. You can do it, let me be very frank, but you have to be honest to your soul, and then you can really get it. I got into belly and love because they threw me out of institute. They didn't want me as a senior resident. No. There was a tussle. They didn't want me at all. Why? What have I done? Have I killed somebody? I don't know. Have I harmed somebody? No. So once I left, they made me a senior resident. I threw them. I don't know, I don't want it. I will go to medical college. But in medical college, Professor Mir Nazir and Professor Munir Khan, they were my colleagues, they were senior colleagues there. Professor Nisar was there. I told Nisar, if he remembers, I told him, these people, I will keep them aching in the mind. Hate keeps a man alive. Hate keeps a man alive. Please hate, start hating. But that should be a proper hate. I wish you had seen the picture of Charlton Heston saying that. That's a biblical story. Hate keeps a man alive. That's a fact. But that hate should be on a proper thing, on truth. Positive hate. So this belly and love, I published concrete cancer in that. And the letter came once I shifted back to institute in '94. Letter came, I was with Professor Behrai Saab in his room, he was the director, and Professor Nazir Saab was there. Letter came to Behrai Saab, and he gave it to me, read it, he was smiling. It was from Ronald Christopher R.C.G. Russell, the editor-in-chief of this. And finally, these things can come and go. What is more important is love, affection, respect. And then finally, at the back end of my life, I wanted to go back to the roots, that was the medical college. And this is the team which loved me, expressed love. And I have no attachments. Please, show me my attachments, anybody. Kindly. I will reply to your answer. Show me one attachment. These patients are attached to our lives, and that's what it is. I am with them, I was with them, I have been very happy, though I am not doing any surgical procedures. They are fantastic laparoscopic surgeons, but they give respect, they give love and affection. That's what you need. Have you ever wondered about the leaves, why they fly in a V-shaped pattern? I leave the question to you. I'll just not speak anything. I'll just go through the slides. You think about it.
This is the answer, sir.
Look at that. I think we have to learn from these. And life of a surgeon is not easy. Rather, anybody's life is not easy.
IHPB presidential oration.
And the future is this. I am telling Salim, I'm telling Chalku today. Of course, Sanjay is more in a liver transplant. I told him the word just now. What I spoke is right here. Robotics is following you. In another 5 years, it will dominate the world. It has a lot of inherent good values. Surgical precision is the most important thing in this. And I tell you, the learning curve is not that steep. Send your youngsters for robotic training. Robotics is going to dominate the world. Only thing is, it is costly affair, and the governments will fund you. I assure you. And you got to have patience, perseverance, passion, purpose. And I love this word from Swami Vivekananda, the last part of it. Things must of necessity be slow. They have to be slow. Understand? Then they are purposeful. And remember at the end, old soldiers never die. They never die. They just fade away. General MacArthur, once he was fighting World War in Korea. I wish you would have seen that General MacArthur, Gregory Peck was the hero in that. You could have seen what a great man he was. He gave a lecture in the White House. Once he was asked by President Roosevelt to withdraw from Korea while he had lost many soldiers. He was not agreeing, but finally he was called back and he delivered at the end this: old soldiers never die. They just fade away. Thank you very much.
Umar, thank you very much for showing you this important journey. I think this has been rightly put today by you for the youngsters, and also not only youngsters, for us also, that we've seen you growing over the years. The journey has been fabulous, and I think you've been very lucky and also blessed to pass on that track. We've seen so much of you and what you presented, and I think it's a big lesson for the youngsters to take clues from that. There are so many areas which are very important. There are so many areas which are so important to make your life successful, and I think the youngsters have taken so many lessons from that. One is probably your commitment, your wisdom, your hard work, your persistence, and also your love and hate for those people in your colleagues. I'm sure there are several lessons in your life path which you need, which youngsters need to take, and we've seen that you're growing all over. But I must say that once I interacted with you and kept you busy and also kept you going, I have been very lucky to really see you absolutely receptive, communicative, efficient, and absolutely, I would say, very, very wise. We're very lucky to have you as a friend, as a colleague, and I think thank you very much for giving your advice to us.
I think I must express my gratitude to Professor Chalko, who called me to be here. And I thought myself very lucky, not only to attend this meeting, just to see some people after a long time. I think we had a number of good lectures, starting with Dr. Nazir. Commendable job. I think you have to appreciate the efforts of the person in a place where you can't do anything. We have progressed a lot. I remember these district and sub-district hospitals, they do cholecystectomies. Now I think we're very happy. They are doing pancreatic surgery, they are doing gastric carcinoma, and this wonderful thing what he showed here, meticulously. I'm certain he must be doing much more than that also. We had another lecture by Professor Chalko. I think actually I also follow him at many this WhatsApp areas, and he's doing a commendable job. I think it's very important that you should do a commendable job, but you should sell it also. Otherwise, people will not know you. You may be doing wonders. We had a wonderful surgeon, Professor Afzalwani. I love him from core of my heart. For his brilliant ideas, he always looks in the reverse direction. And what lot of material he did. But I was always feeling sad. He would not publishing it. Professor Khuru, what I have learned from him, whatever you do, you sell it. People will know you. Otherwise, we saw Dr. Goja showing wonderful things. Grafting, these things, very difficult. It looks very, very simple here. I think he must be sweating. Huh?
Shop and sell.
Yes.
Shop also and sell also.
Yeah, and you should look reverse. Never look. If you remember, I think people, Professor Koro, Professor, others who are once Lawrence pharmacology was there, well, I'm talking of 1973, that edition. The only few lines were in the board letters. Never use nitrates in myocardial infarction. And it was said that anybody who will do that mistake in America or in Europe, that resident will be prosecuted because it will precipitate deaths. But there were people, they showed after some time that nitrate should be the first drug for myocardial infarction. This is how you have to look at science. Nobody thought of in myocardial infarction. And I think that way you can learn in life. This hydatid cyst, once we start this business in institute, the books were written, just puncturing of hydatid is contraindicated because it can cause anaphylaxis and death. And there were 4 deaths reported that time. But finally, now it has become one of the mainstay of treatment. So I think you should look reverse in science. Never look what Dr. Umar said about pancreas, which he has been, I think, associated with a lot of new things, but I know because I closely followed him. But I'm certain you can find mistakes, what he did also, and he can still improve it. That should be your vision. You should not be conventional that this thing or this thing or this. I don't think that should be the case. And I think we heard later then, wonderful. I think it was worth watching those films, not there were videos of Dr. Gosha. I know he's a humble person, but the wonderful work, people have to learn from him. And I think I will urge both Salim and Dr. Kali, you should call him and keep patience for him. This way you can learn from him. Otherwise, by seeing his videos, you cannot learn. And you will see the difficulties what he is facing. So I think you should do it. And hepatolysis, a wonderful thing, I think. I think these are the good ideas. And I think probably in the whole India, we are the only ones having these cases. And I think Dr. Salim, he showed a very good way and crushing using laser. This is how you should work. Having a laparoscope and reaching the secondary, tertiary branches, I think it's a wonderful thing to do. And I remember how many hundreds of patients Dr. Umar helped, because we will send him a lot of patients for resection. And absolutely meticulous results. They are living all those patients. And Umar has a quality, apart from being hard work, he may have arrogance in other areas, but at least in learning, if somebody giving suggestions, he'll be always happy, and he welcomes you. The other were always having debates with you. It was wonderful, and he was doing it. I think he has some hard burdens in life. I think we have reached an age, we should bury all those hard burdens. And not only forgive, we should absolutely forget about it. And finally, I think there was a last lecture. My only thing is that this was a wonderful meeting, and people should conduct such meetings and kindly publish it. And I think there are a lot of youngsters. I will tell them only they should respect their seniors, whatever they may be, whatever their temperament is. But at the same time, seniors have a big duty. They should give a space to the juniors. Then the things will improve. God bless all of you.
Wonderful sessions. Now to conclude, we would like to present the mementos, and for that I call upon stage Professor Dr. Iqbal Salimi, Professor Dr. M.S. Khuru sir to present mementos of appreciation to our speakers of first session. Dr. Nazir Advani sir. Professor Dr. Mushtaq Chalku sir. Now I call upon the chairperson of the first session, Dr. Shaukat Zargar sir. Dr. Nisar Ahmed Wani sir. Dr. Ejaz Ahmed Rathal sir. And a special memento of appreciation to Dr. J.Q. Peer Sahab.
Come on, let's have some claps.
Thank you to the presenters. Yes, sir.
I just want to speak a few things for the youngsters. I think this meeting has been held beyond a meeting. I must say that this is not a normal meeting. This is where there are so many lessons for us, all of us, for the elders and for the youngsters and for everybody. That is important, that you saw such a great demonstration of surgical techniques, innovations. You had wonderful lectures from urban area, number one. Excellent lectures from SMHS. Wonderful lecture from our friend from Delhi, Professor Goja, and such a brilliant demonstration of the life history of Oman. I think beyond that, this meeting, other than educating us, is a great, great lesson to the youngsters, how they can make their lives. And this is the time, probably, everybody should put step on that. And what Shaukat said rightly, first do the right, be ethical, it's very important, be moral, have empathy, very important. I think if you have these three things, then have persistence, diligence, and have wisdom. Take lessons from what you have today. Always go with the tide and against the tide, depends upon what is the lessons. And then always shop and sell. This is what I always tell, that if you have anything, you must shop it rightly. You have and so I would see that many of the youngsters become what Dr. Salim is, and what Dr. Shah is, and what Umar is. And certainly, Goja is really he's a son of the soil, and he has taken us so far, and he is competing with liver transplant surgeons of the country and of the world. And we are so proud.
Now I call upon stage Dr. Abdul Rashid Kumar, Dr. Mubashir Shah, to present the mementos of appreciation to speakers of the second session. 8008, there's a car outside. They need to move the car, I think. So 8008.
कहाँ से होगा 800
Dr. Sanjay Goja, sir.
बीच में ले आए ना
Dr. Iqbal Salim, sir. Dr. Umar Javed Shah, sir. Now I call upon the chairperson of the second session to collect their mementos. Dr. M.S. Khuru, sir. Dr. Nazir Ahmed Salru, sir. Dr. Abdul Rashid Ganai, sir.
आजा take on his behalf. Take on his behalf. Craft check.
Thank you, sir.
I'll request all the seniors to please come here for a photograph because these are memories and I think we should make sure that it keeps something. Rajan, आप आ जाओ. Fayaz साहब. बाकी लोग सारे आ जाओ.